question on that last bill. It talks about case management. What is that going to involve? I think you kind of alluded to it. It might be more than just what we think about medical care. What is that going to involve? What kind of services are going to be provided through Medicaid?
Well, that particular provision of the bill is really speaking to the managed care programs, and it's requiring, as a condition of their full rate, full payment, that they do comprehensive case management in the postpartum area, and that we start to measure things like birth spacing and those sorts of things that we know really contribute to infant mortality. And so much like you probably through the years have been covering the quality component for the nursing home rates, it's the same concept, that there's a certain expectation now as part of your rate that you will do the comprehensive case management services, so we know what we're paying for and we're insisting on that sort of quality. I mean, under the current managed care program, of course, the managed care systems are required to target their top 1% in order to get their rate. So the administration has been moving in that direction. You know, the issue for me, and Charleta and I have talked about this, is that you know, it's up to the health plans to determine what that means for them. And so a lot of times when you're dealing with dual eligible populations, for example, you might be focusing on diabetes or heart disease or high cholesterol, conditions that are usually associated with adults. Certainly nothing wrong with that. We need to really focus on that too. But because this is a clarion call, and I just at my core believe that we have to do more sooner, it's requiring that in this piece, that for a piece of their rate, that this is going to be a requirement for them.
The $25 million investment, can you explain where the savings are that will produce that, and is there going to be any like upfront investment from the state required?
So the $25 million, we arrived at that figures kind of on a pencil to paper calculation, and talking with a lot of the bigger programs in the regions that we've seen, and asked them the question, if we don't supplant resources and we're looking to supplement resources, of the folks that you know that you could serve right now, you know, what would your needs be? And so kind of on the back of a napkin calculation, we got to that 25 million. I think what was in the forefront of our minds is that the significant, you know, we obviously feel passionately about saving kids. We have to do better to save kids. But on the forefront of our minds is the sort of fiscal impact to the state. And I think that no better explains this when I look at this editorial today from the Cleveland Plain Dealer, where they said in 2012, just in Cuyahoga County, where they took care of 2,000 babies that were born before 32 weeks, that was $130 million. $130 million in one county in this state. And, you know, the vast majority of those fall back on Medicaid. And so, you know, for me, when we know that a healthy full-term pregnancy is about $5,000, and right now we're paying $65,000 on average in this one county, we know there are savings there, but we have to be willing to put some resources in. So the programs that are up in Cuyahoga County, I mean, they have some awesome programs there with some awesome results. I mean, they're doing yeoman's work there, but they're not. We got to get to more faster, and so that's where these, what I think, sort of nominal resources are, is trying to leverage those successes to get it to a scale where we can finally start driving those numbers down.
On that point, I guess we have to be committed. And I think that's what we're showing Dr. Gabbe, Moms2Be, and the programs all across the state, that we are serious and we're going to make a serious investment. But if you do the cost-benefit analysis, it's not just about the money. It's about having healthy babies who can live past 1 year of age and grow up and become productive citizens. So if you do the long-range studies of what this means to our community and what it means to the lives of the child and the families, there is no cost that we shouldn't be willing to invest to bring all of these programs up to scale and then to find other programs, other strategies at work.
So you're saying that the requiring the case management will save at least $25 million, and that money will go to these non-Medicaid programs. Is that where the savings comes from?
We're just, for practical reasons, we're just picking up the existing Medicaid savings that we know that exists in this budget based on, projections.
After Medicaid expansion?
That's part of it, but not the entirety, but yes.
Okay.
Other questions?